Okay, so when someone's heart stops, the clock starts kicking loudly. In that moment, you can't be guessing what to do. You need a plan, right? A clear, step-by-step playbook for saving a life. But what if that playbook isn't set in stone? What if it's constantly changing? Well, that's exactly what we're going to dive into today. And, when we're talking about cardiac arrest, the stakes, they couldn't be higher. Get this, the source material says a staggering 90%, that's 90, of people who have a cardiac arrest outside of a hospital, they don't make it. It's a really tough number to hear, but it's definitely not the end of the story.
Yeah, see, survival here isn't just a roll of the dice. It's about science. And that science is always evolving. Every few years, big groups like the American Heart Association sift through mountains of new research to tweak their guidelines. They're constantly refining those step-by-step instructions to give someone the absolute best shot at pulling through.
So in this explainer, we're going to walk through that very playbook. We'll start with the race against time itself. Then we'll unpack the big rules from the 2020 guidelines. After that, we'll look at the advanced toolkit the pros use. We'll even see how the playbook is adapting to new threats, like the opioid crisis. And finally, we'll take a peek at what might be next for the world of resuscitation. All right, first up, the race against time. Success in a cardiac arrest isn't just about one magic bullet. It's a sequence, a series of critical steps that have to happen boom, 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 perfectly and in the right order. They actually call it the chain of survival. And every single link in this chain is vital. It all starts with someone recognizing, hey, this is an emergency, and calling for help. Then, bam, immediate high-quality CPR to keep that blood moving. Then, rapid defibrillation, the shock, to try and reset the heart. After that comes advanced care from paramedics and specialized treatment in the hospital once the heart's going again. But what's really, really interesting here is that last link, recovery. That was new in 2020. It's this huge shift, emphasizing that just surviving isn't enough. We have to think about the patient's long-term health, their physical, cognitive, and emotional recovery. It's a game changer. Okay, so keeping that chain in mind, let's dig into the core rules that actually guide all those actions. This is the 2020 CPR Playbook. Think of these guidelines as the absolute foundation of modern resuscitation. They give clear, science-backed instructions for everybody, from a random person on the street to a full-on medical team. Now, before we get into the nitty-gritty, it's super helpful to know how these guidelines are even written. See, every single recommendation gets 2 grades. First is the class of recommendation. That's how strong the advice is. So class 1 means you absolutely should do this. Then there's the level of evidence. That tells you how good the science is to back it up. Level A is the gold standard. It's supported by top-notch clinical trials. Just keep those 2 ideas in the back of your head because it's going to come up again later and it's pretty important. Okay, so one of the first things you have to get is that not all cardiac arrests are created equal. They're not the same. The very first thing a medical team figures out is the heart's electrical rhythm. And that one piece of information sends them down one of 2 totally different paths. On one side, you've got your shockable rhythms. Think of it like a chaotic electrical storm in the heart that you can often reset with a shock. But on the other side, you have non-shockable rhythms. This is where the heart is either totally silent, flatline, or there's some electricity but no pulse. And in that case, a shock is completely useless. So if you've got a shockable rhythm, like VFib, the playbook is crystal clear. Shock the patient immediately. That is priority number 1. And right after that shock, you don't even pause to think. You go straight back to 2 minutes of hard, fast CPR. It's only after that cycle that you start thinking about drugs, like epinephrine to help blood pressure, or maybe some antiarrhythmics like amiodarone if the shocks just aren't cutting it. But flip the script. For a non-shockable rhythm like asystole, flatline, the whole game plan changes. A shock does nothing here. So the focus is all on the fundamentals, perfect non-stop CPR and getting epinephrine in as early as you possibly can. And while all that's going on, the team is playing detective, trying to hunt down a cause they can actually reverse, like maybe low blood volume or a big blood clot. So the 2020 guidelines brought in a few key tactical changes. For one, they really dialed in the chest compression rate to that sweet spot of 100 to 120 per minute. They also made it clear that a regular IV is the way to go for drugs if you can get it. With an IO, that's where they drill into the bone as a backup plan. There was also this new technique called double sequential defibrillation, where they use 2 defibrillators at once. It was looked at, but honestly, the science just isn't there yet to recommend it. But you know what they did double down on? The importance of giving epinephrine early, especially in those non-shockable rhythms we just talked about. All right, so moving beyond just CPR and shocks, there's an advanced toolkit. We're talking about the pharmacy of resuscitation. In the hands of paramedics and doctors, a few key drugs become really powerful tools to help support the heart.
Let's break down the big three here. First, epinephrine. That's the workhorse. It's given in every type of cardiac arrest to help squeeze blood vessels and get more blood flow to the brain and heart. Then you have amiodarone and lidocaine. These are more like specialized tools. You only bring them out for those stubborn, shockable rhythms that just won't quit after a shock. And finally, there's sodium bicarbonate. Now, this is interesting. It used to be given all the time, but the guidelines now say, nope, don't do it, unless there's a very specific reason, like if you know the person overdosed on certain kinds of antidepressants.
And this just goes to show how this playbook is a living, breathing document. It's always adapting. Take 2023, for example. The AHA pushed out a special update just to deal with a growing and really different kind of cardiac arrest, the kind caused by the opioid crisis. This quote from that update really gets to the core of it. See, unlike a normal heart attack, an arrest from an opioid overdose isn't really a heart problem at its root. It's a breathing problem. The person stops breathing first, and that starves the heart of oxygen until it just stops. And that difference is absolutely critical. And because of that, the whole approach gets turned on its head. The number one priority isn't chest compressions anymore. It's managing the airway and giving breaths. For a bystander, that means doing rescue breathing, trying to stop the heart from ever stopping in the first place. And what about naloxone, the reversal drug? Well, the guidance is super clear. If they're still breathing a little but are in respiratory arrest, give it. But if they are in full-blown cardiac arrest, do not waste time looking for naloxone. High-quality CPR is the priority. Once the heart is stopped, CPR is still king. So all of this, it leads to a really fascinating final question. We've been talking about this playbook like it's a set of concrete, definitive rules. But how solid is the science that's actually holding it all up? Well, when you actually look at the evidence behind the guidelines, you find something kind of shocking. Remember we talked about level A evidence, that gold standard backed by tons of clinical trials? It turns out only 1% of the adult life support recommendations are based on it. Just 1%. In fact, more than half of the guidelines are based on limited data or, get this, just what a group of experts agrees on. Now, hold on. This does not mean the guidelines are wrong. Not at all. I mean, think about it. In a crazy crisis like cardiac arrest, doing perfect randomized trials is almost impossible. And the opinion of experts with years and years of experience is absolutely invaluable. But what this chart really shows us is that resuscitation science, well, it's a field with a lot of unanswered questions. And it tells us we desperately need more solid research. At the end of the day, the playbook we have right now is the absolute best blueprint we've got for saving a life. It's the best of our current science and wisdom all rolled into one. But it's a living document, a story that's still being written. So I guess the real challenge is for the next generation to take those pages that are based on expert opinion and turn them into chapters of hard, scientific proof. To finally, once and for all, fill in the missing pages of the playbook